Hello, my name is Christian Jones, and today I'll be doing a presentation on fishbone analysis of CLABSI in the neuromedical ICU. So what is a CLABSI and why is it important? CLABSI stands for Central Line Acquired Bloodstream Infections, and it is important because thousands of people lose their lives to CLABSI infections all the time that can lead to sepsis and other ailments. And it puts a strain on the healthcare system, costing billions of dollars for healthcare payers and organizations alike. So, what factors contribute to central line associated bloodstream infection? A lot of it, as I mentioned in the previous slide, some of it could be like lack of managerial policy oversight, so managers not coming by, or charge nurses even not coming by during rounds or towards the end of shift to make sure that patients' lines look clean, they're in the proper place, or they don't look out of order or messy, or the line itself isn't kinked. We want to make sure that our lines stay as straight and well protected as possible in a clean area, so we can help to reduce some of that. And managers and charge nurses are a big help in that regard, and it can make a difference. Another would be using evidence-based central line protocols. Knowing where placement goes, and this goes for physicians, and really it's a top-down order. So from managers and even our CNOs, but it's a top-down policy that should be implemented in all hospitals and organizations that use central line placements. One of them would be like physicians choosing proper places that will have less opportunity for infections. So maybe not going for a femoral artery at first. Instead, maybe looking for a IJ. Yes, IJs are also high. I mean, central line placements in general are just very high acuity for infections. It comes with the territory, so it's very important that nurses and physicians not only just have good placement, but nurses also make sure that they are keeping the area clean at all times, and most times as they can, as they're getting these medications and having this large open wound or incision for the patient. So having a protocol to protect lines, have a good proper line placement, checking for certain anatomical issues that may be coming up with every patient. Every patient is different, so their anatomy is going to be different. So we want to make sure that those things are also in place properly. So getting a X-ray after you've placed the line to make sure it's in a good position, and seeing and checking the site as it's getting medications through it to make sure that it's running properly and safely. Another issue that we do see, though, however, with CLABSIs is having a lack of supplies in the evenings. Now, I'm a little biased being a night nurse. We typically run into a lot of issues towards the evening because supplies start to run low, and we don't have an overnight inventory staff member that comes and makes sure that we have plenty of supplies to get us through the evening. So we've had to go, and I know I did in the beginning of my nursing career, I had to make do until the morning, until we could get some help. Weekends is also another difficult time period for us as night nurses, because the inventory staff don't work weekends, so we have to make do with what we have, and that can be dangerous and costly for the organization as well as for the patient. So looking further into the cost of hospitals, for example, CLABSIs create a significant financial burden for hospitals. Patients who develop bloodstream infections often require prolonged ICU stays, more broad-spectrum antibiotic therapies, and other additional interventions such as CTs and chest X-rays. Hospitals may also experience a decrease in reimbursement and financial penalties related to hospital-acquired infection rates like CLABSIs. These infections impact not only patient outcomes, but also organizational sustainability and resource allocation. So, personally as a nurse, that's more money out of our pockets, less opportunity for us to get better supplies, and just making sure that we're staffed properly. So lack of managerial and policy oversight is another aspect. We want to make sure that there is a policy within an organization our hospital to make sure that they have something in place for CVC placements, which is a central vein catheter, another term for central line. Um, we want to make sure our managers' oversight plays a major role in infection prevention. When leadership monitoring and accountability are inconsistent, staff may unintentionally deviate from the best practices. So, limited leadership visibility during night shift and weekends may further contribute to inconsistent adherence to CLABSI prevention measures that we see. Like I mentioned before in a previous slide, having managers come towards the end of shift to make sure lines look good, clean, touch base with the nurses to see how the line is running, if there's any, like I mentioned earlier, extravasation or infiltration or any kink issues within the line that need to be addressed. I think it's important to have managerial and charge nurses oversight at the bedside to also help reduce infections or potential infections. So a lack of evidence-based central line protocol, I feel, is essential for nurses and clinician staff to have when placing central lines. It's important to stay up to date with these things so that we know the best practices. Evidence-based central line protocols are essential for preventing bloodline infections. Inconsistent adherence to standardized protocols increases the likelihood of contamination and infection. Implementing evidence-based maintenance bundles and ensuring ongoing staff competency can significantly reduce CLABSI rates. And fortunately for us at our hospital, they have developed a better system, and I'm grateful for that because it streamlines the process, and we know exactly as a nurse where to go when something isn't right, doesn't feel right, doesn't look right. We have a protocol that we can always follow and follow the chain of command to get us the essential help that we need. So limited inventory availability during nights and weekends does create significant barriers to safe patient care. Nurses may experience delays in obtaining sterile technique supplies needed for proper line maintenance. These interruptions can negatively impact workflow efficiency and increase the risk of infection due to delayed or compromised procedures. So here's my fishbone analysis diagram, just showing of exactly what we've kind of been discussing so far: a protocol, hospital costs, managerial policy, oversight, and a lack of inventory. These all can lead to CLABSIs, as well as CAUTIs, which are community-acquired urinary tract infections. They can lead to aspiration pneumonia. So it's very important that all these things and similar of different type of hospital or community-acquired infections, it's important to have protocols, managerial oversights, and inventory to really look over, because then if you don't, you will end up having those hospital costs that end up being just super detrimental to patient outcomes, patient satisfaction, as well as safety, importantly. So for Fishbone analysis summary, the Fishbone analysis demonstrates that CLABSI development is a multifactorial and deeply connected to organizational systems. Effective prevention requires collaboration between leadership, infection prevention teams, and bedside nurses to ensure consistent standard care. So several quality improvement strategies can help reduce CLABSI rates. Leadership involvement, standardized evidence-based care, and improved resource availability are all essential components of a successful infection prevention initiative. So we do use this a lot in our hospital, especially when we're getting new supplies or we need to be educated or re-educated, or so just new information coming out that's evidence-based or policy-based. And this is an in-service or educational session. They usually don't take long, maybe 5 to 10 minutes. You don't want to be away from your patients too long in the ICU. So they'll usually bring us around and we'll have materials or new supplies or just re-education, like as I mentioned. So this would be an in-service I would use on the unit. This is a PDSA model. Plan stands for Plan, Do, Study, and Act model. So we would use this in-service to focus on improving Class B prevention through evidence-based education, standardized practice, and interdisciplinary collaboration. The PDSA model allows the unit to continuously evaluate and improve infection prevention efforts while supporting nursing staff with the education and resources needed for safe patient care. That's why we use this type of model, and this is why the model was suggested to use. I see this model used often. It's very common. So yeah, I would definitely, type of supplies, I would have an actual central line catheter on hand so so staff can see it, feel it, use it. Then I would explain what and how it's placed and why we place it in specific areas, such as mentioned earlier, the internal jugular vein, or maybe a subclavian vein, or a femoral at worst come. If a patient has a tough anatomy and doctors can't see or can't get the line in, and the other two, I have seen very commonly that they'll use a femoral artery vein. The downside to using a femoral, or the further you go south from the IJ down, it can be more, and it is higher potential acuity of infection. So you have to be very clean about changing the dressing with the sterile technique, as well as making sure that dressing stays clean as much as possible. So when giving bed baths and making sure the line isn't kinked, and it doesn't cause infiltration or agitation to the area where the medication is going through it, or just having the line in place and inflaming that area. That will help to deduce and reduce the infection rate for having eclampsia in the femoral area. But honestly, that same rhetoric goes for the IJ as well as the subclavian. So it's across the board. It's just a little bit higher and more focused when you're looking at areas that have more potential harm, like a femoral artery. So yeah, I would definitely have that within the info session with nursing staff and staff alike. As mentioned, I would let them use it, see it, feel it, show them different examples of what it looks like when a central line looks good comparatively when a central line looks bad, and things they could look out for. And then just how to consistently monitor, make sure that they know how to use the supplies for a dressing change, give opportunity to the nursing staff to do it and show and teach one another. It wouldn't take long, but it's something that I would implement quick. There's something that they can do, and just maybe it might be a reinforcement that they've done before. They're like, oh yeah, I remember how to do it. Or it could be like, oh, I never knew that, or this is something different. And as well as updates for the new protocols or new evidence-based practices that we're using as nurses and staff. So in conclusion, CLABSIs remain a significant patient safety concern within the ICU setting. Addressing leadership oversight, protocol standardization, and supply availability can improve patient outcomes and reduce infection rates. Preventing CLABSIs require a proactive, systems-based approach focused on patient safety and evidence-based care. 100% agree. Like I said, I'm very much looking forward to our hospital continuing to do good work in this regard and having standardized care for this. We actually just was awarded through our hospital a couple weeks ago for having the least amount of CLABSIs we've had in our unit in over a year, which has been 0. So I'm very happy and pleased to hear that, and glad to see that my contribution as well as my other nursing staff have contributed into doing that and making sure that our patients are safe, but also getting the required care that they deserve and need. These are my references. Thank you so much for listening. I hope this is helpful, and have a good one. Take care.